I miss being with you there in person. So we'll go to the topic neovascular glaucoma. Neovascular glaucoma is a severely blinding secondary glaucoma. We know it's kind of a medical emergency. With increasing prevalence of diabetes mellitus, the prevalence of neovascular glaucoma is also far increasing. Although it forms a small chunk of all the secondary glaucomas that we have, what is very important is close to about 20% of untreated or inadequately treated patients with proliferative diabetic retinopathy develop neovascular glaucoma. What happens in this condition is the new blood vessels that develop in the angle obstruct the trabecular meshwork and can develop a peripheral anterior synechia and results in rise in intraocular pressure. The causes are variable, including the ocular and systemic causes. Of all the causes of neovascular glaucoma, diabetic retinopathy, the proliferative stage, central retinal and branch retinal vein occlusion, and ocular ischemic syndrome constitute about 80% of all NVGs. When we see neovascular glaucoma in a child or a young adult, especially if it is unilateral, always rule out possibility of other serious conditions like intraocular tumors as well. Ocular ischemic syndrome, although is a smaller component compared to PDR and CRVO, what is very important is these patients usually present with vision which is relatively good. Posterior segment may be minimally affected. The intraocular pressure control is most important to preserve the vision in these eyes. And it's also important to note that several of these patients can present with an NVG related to OIS, where they may be harboring a serious systemic condition like Takayasu's arteritis or carotid occlusive disease. Early stages are asymptomatic, but the condition can deteriorate very rapidly, presenting with severe pain and decrease in vision. A high degree of suspicion is very important for early diagnosis. Observing the twigs of new vessels at the pupillary margin and the new vessels in the angle at an open angle stage are very important to be able to diagnose this condition early and treat appropriately. Undilated slit lamp evaluation and gonioscopy are important to pick up the subtle changes. Multimodal imaging, including the OCTA, is very important to pick up the condition early and treat it aggressively. We know the retinal ischemia is the cause of the neovascular glaucoma, and it's very important to take care of this ischemia before we go ahead and do anything for the rise in intraocular pressure. So posterior segment pathology needs to be treated aggressively, whether it is with laser, anti-VEGF, or with vitrectomy. Elevated intraocular pressure is treated medically and, if necessary, with surgery. Anti-inflammatory medications and cycloplegics are very helpful to relieve the inflammation and pain. The management protocol basically depends upon the etiology of the posterior segment pathology, of etiology of neovascular glaucoma, rise in intraocular pressure or normal intraocular pressure, and presence of useful vision. So based on which there are various ways or various methods of treatment of the same condition. Posterior segment pathology should be aggressively treated with a pan-retinal photocoagulation, and when necessary, anti-VEGF injections can be given. What is very important to note is PRP should be done very quickly, possibly if the time allows and if the patient's condition allows, within a week. Anti-VEGF, when somebody is using it, is very important to know that it has a short shelf life. So you can't just give an anti-VEGF and leave it there. The actual treatment has to be permanent, which means a PRP, or in case PRP is not possible, another way of treating it, whether it is surgically or with a laser, is something one has to think of. And anti-VEGF is very useful in patients prior to glaucoma filtering surgery. The glaucoma management depends upon whether the angles are open or closed, and depends upon the height of intraocular pressure. At an open angle stage, when we diagnose neovascular glaucoma, sometimes we may get away without a need for a glaucoma filtering surgery. However, if the angles are closed, glaucoma filtering surgery is definitely necessary. The treatment for elevated intraocular pressure is both medical and surgical. Often with medical treatment, we are able to help the initial stages, but until the time the posterior segment pathology is taken care of, but most often they require a surgery or a laser to control the intraocular pressures. Some of the points that one needs to remember, especially when considering surgery, is that if new vessels have regressed and inflammation has resolved, trabeculectomy with mitomycin C is still my first choice and has reasonable success. Few procedures have better results in the presence of persistent new vessels and inflammation. TSCPC is often used only in situations where the visual acuity is not so good, or in situations where it is not possible to perform other procedures. While doing trabeculectomy, it is very important to note that prior treatment of the retinal pathology has to be appropriate. Anti-VEGF, when necessary, has to be given, especially when new vessels are still persisting. Cauterization of the peripheral iris and performing a safe iridectomy is very important to prevent serious hyphema in these eyes. And of course, post-operatively, gradual taper of steroids and cycloplegics are very useful. Once the posterior segment is taken care of and adequate precautions are taken during an antifibrotic used trabeculectomy, we can have reasonable success even in the long term in these patients. We actually looked at the outcomes of trabeculectomy in NVG, but we looked at it in a slightly different way, where we looked at the sub classes of NVG. That means the patients with PDR, patients with CRVO and OAS. And we found that those patients with proliferative diabetic retinopathy, the trabeculectomy did not do very well in the long term. However, the ocular ischemic syndrome and the central retinal vein occlusion patients had reasonable success even in long term. And we also found older age, persistent new vessels, and delayed surgery or need for a more number of anti-VEGF injections were associated with higher risk of failure of trabeculectomy. In situations where the conjunctiva is scarred or the new vessels are still persistent, one may have to think in terms of a glaucoma drainage device procedure, but care has to be taken to make sure that these eyes that are difficult and ischemic eyes have to be handled appropriately during the surgery as well as in the post-operative period. With appropriate intervention, one will be able to get good pressure control as well as maintain the vision in the long term. The success rate of valved and non-valved implants seem to be similar in patients with NVG. However, immediate pressure control with valved implants seems to be something that we all would want. So my personal choice would be to do a valved implant in these patients. Also, there is a lesser possibility of post-operative hypotony. Cyclophotocoagulation is something that is reserved usually for eyes with poor visual potential, or to combine it with an ARC, especially if the media is hazy. However, hypotony and hyphema are two problems that one needs to remember that can be detrimental in seeing eyes. We also recently looked at outcomes of neovascular glaucoma when they presented early. That means these patients who presented to us from two different countries, in the UK as a developed country as well as in India, we looked at where the presenting features or the way we treat in these two different countries, how did it affect the visual acuity when they presented with reasonable vision. So this cohort included about 92 eyes from Indian cohort and 59 eyes from the UK cohort. And we looked at the stability of vision, of improvement of more than 2 Snellen line or stable vision in these patients, and close to about 43% from Indian cohort and 52% in the UK cohort alone maintained the vision, which means close to only about 50% of these patients, although they presented with visual acuity better than 2200, were able to retain the same vision at the end of 30 months of follow-up. What was very interesting is we found what was different in Indian cohort was that significant number of patients who presented in the Indian cohort to a tertiary eye care center did not have a PRP prior to presentation and had significantly more number of anti-VEGF injections prior to presentation. This was different in the UK cohort compared to what we found. So what is very important is not just the early diagnosis, but early and adequate and aggressive treatment of the posterior segment is very, very important for better long-term outcomes in these patients. To summarize, neovascular glaucoma is a difficult secondary glaucoma. The complications are secondary to a retinal pathology as well as damage to the optic nerve because of high intraocular pressure. Prevention is always better So by regular follow-up of diabetic patients, trying to pick up the disease early, especially if they have a proliferative stage, early diagnosis, and to emphasize aggressive and appropriate treatment is very, very useful to save vision in these patients. And of course, they require a long-term follow-up because many of them have systemic condition, which again is a condition which may be progressing, and hence a long-term follow-up would be necessary. Thank you so much for your attention.
Thank you. Thank you very much, Dr. Sirisha. Dr. Sirisha is in another meeting and so is unable to join us online. May I request Dr. Devendra's opinion on how we go support? Dr. Sirisha will join us in 2 minutes. Dr. Devendra, your mic, please. What is your method of choice to manage these patients?
I think it's comprehensive talk. He explained everything clearly. As neovascular glaucoma is concerned, so first at most we have looked for the pathology, why neovascular glaucoma is there. So first treat the cause, because if you're not treating the cause, doesn't make sense to do any kind of management you are doing. Though in my clinical practice, I used to do as a valve surgery as a first choice, but in certain cases, and we keep the trap at the MMC also for second line choice, or I will say in certain patients we do the trap at the MMC and they have good outcome. But there's a different opinion. Some people go for directly for the GDD as I used to do, but in certain cases trap at the MMC also works well.
If I may add, I agree with Dr. Devendra, but don't think that all NVGs need tube. I mean, if the angle is open and there is no 360-degree PAS, trap with MMC works very well because the intravitreal anti-VEGF that you give pre-op, it helps in the establishment of the bleb, and some of the most beautiful diffuse blebs that I get are my patients who are having this anti-VEGF injections and then go on to have trabeculectomy. The second more important point that I would like to make is PRP is necessary. Anti-VEGFs are helpful, but if you have a patient where they have started the PRP, but the pressure is refusing to come below 30, 40, go ahead, operate, and continue the PRP later. I have seen many an eye which has been lost because they want to wait for that 3 sittings to be completed, and they wait for 2 weeks, sometimes 3 weeks. Patient, misses a follow-up, the PRP gets delayed, and in the process loses his or her vision. So do not wait. If your eye pressure is not coming down, intravitreal anti-VEGF followed by trabeculectomy or AGV, whatever you deem fit in that particular case, go ahead and manage the IOP because vision can be salvaged, and these eyes progress very fast.
And the anterior retinal cryo?
Anterior retinal cryo, if the new vessels are not, going, but if you do that immediately pre-op before doing a trabeculectomy, it's not going to help. So I would more focus on surgery, getting the eye pressure down, and then anti-VEGF. Sometimes there are a couple of patients of mine who keep on getting new vessels. So the retina people manage them. The ocular ischemia is quite severe, so serial anti-VEGF injections. After the necessary PRP and fill-in PRP, everything has been done.
Yes.
So I will just want to add one more thing. Recently, we have started doing the gonio-assisted trabeculotomy in the NVG cases also. Though I have the very short follow-up, so I can't comment on it, but that also in few cases when NBI is regress nicely, PRP has been done, you can have one choice, initial choice, you can do such kind of MIGS initial stage, but you have to be very, very selective. Then later on go for the trap, then go for the GDD, whatever works in your hand. So that one choice we can have.
One more choice.
Yep.
Dr. Thomas George?
This MIGS you're talking about is a temporary time to buy time for trap or instead of trap? Trap or GDD?
I personally feel if damage is not much, trap really works for 3 year, 4 year, not more than that in my NVG cases. So if I feel really advanced damage, IP is very high, so I directly go for the GDD. I think it solved our purpose.
Can I add?
Yeah, ma'am. Yeah, please.
Yeah, so I think in the video we have very clearly covered that if the new vessels have regressed, most of it regresses, especially if it is a posterior segment is treated very well, except in patients with ocular ischemic syndrome. So in patients with ocular ischemic syndrome, whatever you do, the new vessels don't regress completely. But that doesn't mean that your trabeculectomy does not work. Okay, so we have to differentiate between the two. Are these new vessels of ischemia because of the anterior segment ischemia, or is it response of the posterior segment because of which you have new vessels on the anterior segment? And then based on which you plan whether it is trab or tube. And to talk about GAT in these eyes, I think we need to be very, very careful before choosing GAT in or any angle-based surgeries in patients with NVG. Unless this is an open-angle glaucoma primarily has developed neovascular glaucoma as a secondary disease in these eyes, and you have treated over a long time, pressures go uncontrolled, and then you want to treat it like a primary open-angle glaucoma, it's a different issue. But I think at least the message should go that angle-based procedures are not something that you would want to use in patients with NVG.
Yeah, I agree, madam. I told you only few selected cases you can try it. One of the option actually. We have the short series. Probably will come out with the long-term outcome. Then I can talk better. But in the selected cases, you can try the GAT once you are master in doing GAT. So, madam, what's your choice of GDD treating the NVG? You go for AGB or you go for RD and or clear path?
I think we have a talk in the afternoon, but for an NVG where you want an immediate reduction in intraocular pressure, I would prefer to use a valve implant, or sometimes like nowadays we are also using a Paul glaucoma implant, but otherwise a non-valve implant, I think I'm a little careful about using it. That would not be my first choice. A valve implant or a Paul glaucoma implant where what I'm saying is you have an immediate reduction in intraocular pressure. You're not ligating the tube and you're waiting for 5 weeks for the IOP to go down. By then you may even lose the eye.
Sirisha, Paul's implant is available in India?
Yeah, it's not available commercially, but it's a part of a study that we are doing. So we've had really good results with that.
Because I was going to make a statement about this. All our tubes are too big for the periphery of anterior chamber. It will be causing some endothelial damage right through. So one more reason to prefer a trap whenever possible.
Yeah, I agree with you, George.
Even sulcus placement of the tube. So if you are worried about endothelial decompensation, if it is a pseudophakic patient, cut the bevel backwards and place it behind the iris in front of the IOL. I do that whenever I can because long-term incidence of endothelial decompensation after a valve, when you go on seeing the patients, you realize that it's a sizable number. And if you can place it in the sulcus, please go ahead. I mean.
Yeah, apart from that, this is one. Yeah. So I will share that. So one more method is there when we probably some of the people have faced challenge to put into the sulcus because once you are not expert, it's difficult to find the sulcus. So what you can do, you can make a surgical PI. After putting the surgical PI, place the tube under the iris. So that way you can avoid the endothelial damage.
But always cut the bevel backwards, bevel facing backwards.
Final comments, Dr. Sirisha?
Yeah, in fact, all pseudophakic eyes, I always place the tube in the sulcus, and even in phakic eyes, in situations like, let's say, for IP syndrome, you hardly have any anterior chamber there. So even in those eyes, one has to be careful in placing the tube in the sulcus in a phakic eye because when you're trying to enter with a needle in the anterior chamber, you may accidentally hit the crystalline lens. So in situations like that, I modify it and I use a 26 gauge needle to enter a controlled entry and place the tube in the sulcus. Sulcus placement, anything that is away from the corneal endothelium is definitely something that all of us will look forward to.
Thank you. Thank you very much, Dr. Sirisha, and thank you all the speakers of this session. We come to the end of this session. Thank you, the chairperson and all the speakers. Thank you.
With this, we conclude our second session. We would like to present the memento to those who participated in this session. I invite Dr. E.J. Mani to hand over the memento to Dr. Gauri J. Murthy. Dr. Girija K. Dr. Thomas Arun Verghese. Dr. Abhilash Nair. Dr. Thomas George. Thank you, sir.